Hello, and thank you very much for joining us today. I'm Augustine Choi, Dean of Weill Cornell Medicine, and I'm pleased to present to you our Weill Cornell Medicine Insights webinar series. Over the next several weeks, we'll be presenting a series of lively and interactive discussions with distinguished Weill Cornell faculty members who are experts in a range of important topics during these extraordinary times. Each of us has faced our own unique challenges over these last few months, and our hope is that this series can help us continue to stay connected and informed. Today's webinar is Health Equities and Racial Disparities, the Pandemic Within a Pandemic. Today's Weill Cornell faculty panelists, all authorities in their respective fields, are Drs. Monika Safford, Joy Howell, and Vanessa Rouzier. They'll be joined by a moderator, Dr. Ibrahim, Senior Associate Dean of Diversity and Inclusion. Thank you very much again for joining us today and for being part of the Weill Cornell Medicine family. Now, I'll turn it over to Dr. Ibrahim to get things started.
Good afternoon. On behalf of Weill Cornell Medicine, I'm pleased to welcome you to this webinar on healthcare disparities and the pandemic. I'm Ibrahim, Senior Associate Dean for Diversity and Inclusion and Professor of Population Health Sciences. As many of you know, the last several months have been challenging for all of us. First, we witnessed the devastating impact of a new and novel virus on our communities and healthcare systems. Combating this new and dangerous disease is the equally devastating social injustice crisis of the last several months, not to mention the economic fallout from all of these tragedies. As Dean Joy often says, it's like experiencing the 1918 pandemic, the Great Depression, and the civil rights struggle of the 60s all at once. But the focus of our webinar today is the impact of COVID pandemic on the long-standing pandemic of healthcare disparities. There have been numerous early reports of marked racial and ethnic and socioeconomic disparities in COVID disease prevalence and mortality across the country. From Chicago to Milwaukee to New Orleans, minority communities have been disproportionately impacted by the pandemic. Within New York City, there were similar reports early showing that, for instance, African American and Hispanic community members have been hit harder by the pandemic. Within our healthcare system, we also know that there have been variations from hospital to hospital in COVID-related outcomes among hospitalized patients. Just to give you an example, the overall COVID death rate among hospitalized patients at our NYP Weill Cornell Hospital was early on about 15%. That number was about 26% for NYP Queens, a site that has been hit hard and provides care to more diverse patient populations. Also, between March 1st and May 11th, at the height of the pandemic in New York City, more than 8,800 patients presented to our emergency medicine room for care. Of these patients, about 18% were African American and about 13% Hispanic. But what's notable from our COVID institutional data registry is that among patients who were tested for the virus at our hospital, the positivity rate was about 28% for white patients, 37% for Black patients, and about 59% for Hispanic patients. These numbers and these figures actually happen to be the case for the nation at large today. But more recently and more positively, there is some data emerging that shows that although the pandemic continues to disproportionately impact socially vulnerable populations, among patients hospitalized for care at equally high quality settings, differences in hospital-based outcomes when adjusted for all baseline comorbidities such as cardiovascular disease, diabetes, obesity, or hypertension, are actually encouragingly similar across the demographic groups. But what this point really sort of emphasizes for us is the importance of access to high quality care to not only reduce the impact of the pandemic, but to also reduce disparities in healthcare outcomes. But our approach to the pandemic of COVID within the pandemic of healthcare disparities has really several fronts or dimensions. There is the research dimension. We need to conduct the rigorous research needed to understand the impact of the disease across different demographic groups. And we need to do the research to help design the interventions we need for our communities and to prepare the nation for the future pandemics. There is also the clinical dimension or front. It's important that we assure equality of access to high quality care. It's also important to improve access to newer forms of healthcare delivery, such as telemedicine and virtual care. Finally, there is the global dimension to both the virus and the inequalities in access to care. After all, we live in an increasingly globalized community where a sick patient in Wuhan, China, or in Haiti is a threat to the health of all communities everywhere. So I'm delighted this afternoon to welcome a panel of experts, all members of our Weill Cornell Medicine faculty, who will be having a discussion with us on this issue. So let me introduce our experts. First is Dr. Monika Safford. As many of you know, Dr. Safford is the Chief of General Internal Medicine at Weill Cornell Medicine at NYP. She's also the Director of the Cornell Center for Health Equity. Dr. Safford is also an NIH-funded investigator of healthcare disparities, particularly in the area of cardiovascular diseases. Our second panelist is Dr. Joy Howell. Dr. Joy Howell is an Associate Professor of Pediatrics and Assistant Dean of Student Diversity and Life. And our last but not least panelist is Dr. Vanessa Rouzier, who is an Assistant Professor of Medicine and a member of Rescue program in Haiti, which has had a long-standing relationship with our Center for Global Health here at Weill Cornell Medicine. So each of these experts will take questions from me initially, but then later on, after 30 minutes, I would like to open the conversation to the audience so that you could also ask these questions by posting them on the chat room. So with that, let me start. Let me start with Dr. Safford. Dr. Safford, what do you see as the root cause of healthcare inequities in the United States?
Thank you very much, Saeed, and it's an honor to be asked to participate in this discussion because obviously I focused my research on this question. And I think the COVID epidemic really brings into sharp focus problems that have pre-existed COVID for many, many years. And the bottom line here is that it's all joined at the hip. Just like a patient is not a person with diabetes, it is a person. This injustice and our white supremacist roots in our country, not surprisingly, influenced the way that we structured our institutions. And it should come as no surprise that if those institutions were founded with a philosophy of racism, that we continue to perceive that in our institutions today. And that is my opinion about why we have health inequities. It's because of our social structure. It's embedded into our structure. So what do I mean by that? Well, in healthcare, a recent hullabaloo is around the fact that we often adjust for race in some of the tools that we use to decide whether people should get care. And a very good example is renal function. There is a widely used estimating equation, and it's adjusted for race because when the physicians and the scientists who first developed this tool, they noticed that persistently African Americans had worse values than everybody else. So they thought, well, that must be something that's associated with race. So we'll just adjust that. And there was a recent paper published in a very high impact journal, the New England Journal of Medicine, that demonstrated that has an impact by delaying care. And you can actually calculate the number of lives that were lost as a result of this inadvertent sort of blind eye to the structure of what we've done, where this is really embedded into everything that we do in a way that we're not really cognizant. So I think one of the great hopes that I have is that we can recognize that health inequity is not just about the healthcare system, and it's not just about doctors and about patients. It's really about social justice and about taking a very long look at the way we have structured our institutions and carefully examining together where racism is embedded and how to get rid of it. And I think this example of the renal equation is a very good example of how we can re-examine everything that we do through this lens and ask ourselves, is this something that we can change that would potentially make healthcare more equitable? So I'll just stop there and say that, you asked me what's the root cause. I think racism is the taproot cause. Just like any kind of weed that you try to get rid of, if you leave that very long taproot in, the weed always comes back. So if we really want to eradicate this, we have to be very serious and dig deep, get rid of it, and move in a better direction together, which requires first going to very uncomfortable places and having very uncomfortable discussions, but beginning to teach our children about our past the way it actually was, and not the way we wish it had been.
Thank you. That's a really a very comprehensive answer to a very complicated question. Thank you. Let me go to Dr. Rouzier. Dr. Rouzier, I realize you are in Haiti, and there is a sort of a tropical storm. So we will understand if for some reason you suddenly get cut off. But the question I have for you is, the COVID pandemic has put a severe strain on Haiti, where you are based as a member of the JESCU Center. So how historically has the Haitian population fared in previous health crises, and how did you build on your experience fighting other diseases when faced with the COVID crisis?
Thank you, Saeed, and thank you for the opportunity to have me on the call from Haiti. And I really apologize for the bad internet if I get cut off or if it's choppy. Indeed, we have a tropical storm coming. Haiti, unfortunately, has been prone to significant natural catastrophes and political instability. And it's a very little country, but it has such a tremendous history. And it's actually that experience and that expertise, if you will, in being used to having to deal with natural catastrophes that has helped us. So at JESCU, where we are based, which is a partnership with Weill Cornell University, our expertise with contingency planning has been key. It's been paramount in our ability to respond to natural disasters, social and political instability. We have mastered, if you may, the art of contingency planning, and it had been refined over the years. With a level alert with 1 to 4, with 4 being the highest and the most severe. Haiti has been prone to hurricanes, as we have one on its way now, flooding, and major epidemics. So we've been founded since 1982, and we faced HIV/AIDS from the inception of its disease, and that's why the name JESCU is this funny acronym, because the word AIDS didn't exist in 1982. So having faced AIDS and then the multiple epidemics afterwards, we had Zika, chikungunya, the massive cholera outbreak in 2010, which occurred just 10 months after the catastrophic earthquake of January 2010, that really impacted with over 300,000 deaths, 1.5 million people displaced, 120% of the GDP of the country was lost. So it's been an obligation for us to have contingencies in place to respond to pandemics. So when COVID came, it was just another issue to deal with. And it's been wonderful to have those mechanisms already in place. And what's been important is the flexibility in the response.
Well, I'm afraid the tropical storm has struck. So let me go now back to Dr. Safford. Dr. Safford, you've been NIH funded for many, many years. What has your research shown in terms of how improving access to care can improve health outcomes, even with serious diseases like COVID?
So, I mean, it makes a big difference. It's, for example, health insurance. We've done a fair amount of research that shows that you can definitely see differences in health outcomes and life expectancy for people who don't have health insurance. So we do have Medicare once people reach the age of 65, or if they become disabled before they reach age 65. And you see some of the access issues sort of drop off because people do have better access. But before age 65 is actually when we see the biggest health inequities. And part of that is that we have shorter life expectancy. By the time you make it to 65, there's something special about you. But it's clear that people who lack health insurance definitely have worse health outcomes. I don't think that would be a surprise to anybody. So that's sort of the most basic access issue. But there are other studies that show, and I think, Saeed, you actually did one of these studies, that it really matters where you go. So if you go to a lower quality hospital, you may get lower quality of care, and that may impact your health outcomes. So for example, if you have a heart attack and you go to a small community hospital that doesn't necessarily have a lot of specialists, and it doesn't have the required laboratories and interventions available, if you're lucky, you may do well. But we know that there are interventions that have had a very big impact on heart disease outcomes. And if they are not available to you, then you can't benefit from them. And one of the realities that we have, and this definitely was seen in COVID, people wonder why are there so many people of color who are so disproportionately impacted? And a lot of it can be attributed to access. So if you think about where do New Yorkers live who are Black and brown people, many of them live in the Bronx, in Queens, in Brooklyn. Fewer of them live in Manhattan. And in those neighborhoods, they often have many families, large families living in relatively small apartments. So there's a lot of crowding. So when people first started coming down with COVID, there were reports of ambulances going to pick somebody up where everybody in the family was sick, and the sickest person was the one who was being taken to the hospital. So we are discovering that, especially COVID, but this is true of a number of other viruses, that the more exposure you have while you're incubating the virus, the worse you get, the more severe your illness is. So you can imagine that if people are coughing all over each other and somebody hasn't gotten it yet, that their exposure to the number of viral particles is much lower. And there are reports that are confirming this. We definitely saw this in New York City. Furthermore, where are the best hospitals? Well, they're not in inner city Brooklyn or in inner city Bronx, where the lowest income people live. So if you're really sick, you're going to be taken to the nearest hospital. And the hospitals that were most likely to be overwhelmed were smaller hospitals that were not part of large healthcare systems, and they had no reserves. So they became overwhelmed the quickest, and that's where a lot of our people of color had to get their healthcare. So access plays an enormous role. We've also done some studies that show that health professional shortage areas, this is a designation by HRSA, a calculation about how many physicians you should have per capita, and there are areas in the country where we don't have enough. And there are some health outcomes that are worse in those areas. So access is very, very important. But I think a really important thing to recognize, we're physicians, we're a medical college, we're a health system. So that's what we do for a living. But in terms of our overall impact on health is actually relatively minor. So there are estimates from the social sciences that genetics plays about 30% of a role in determining what your health is going to look like. Our health behaviors, whether we exercise enough and whether we're healthy in what we eat, whether we avoid cigarette smoking, those kinds of health behaviors have a 40% influence. And social determinants like access to care, institutionalized racism, these things have about a 20 or 30% influence, which leaves about a 10% influence for healthcare. And that's why I think it's so important for us to recognize that we can have the absolute best healthcare systems in the world with everybody having access, and we would still have health inequities. In fact, you see health inequities in Canada. You see them in this gigantic 17 million person study that was published a couple of weeks ago from the United Kingdom. They have health inequities there. So access is an absolutely critical, important factor, but it's by far not the whole solution.
Thank you. So not only is it important to health what happens at your community, but when all else fails and you need care, access to care is important. But not only is access to care important, but where you go for care matters. And I think that's a really beautiful way of framing what you just said. Now, let me go back to Dr. Howell. What change have you seen as a result of increased diversity in your department?
So I would say that most of our inroads, most of our progress have been in the area of education and climate. As recently as 2 days ago, we had an anti-bias workshop, which with the support of my chair was beautifully attended. We had 140 participants, and that's just the full-time faculty. We have sought to have multiple fora where we can have not necessarily simply safe discussions, but brave discussions and get to the heart of matters about race, racism, systems of oppression. And so I would say our greatest inroads have been in that arena. We are still looking to make further progress as it relates to recruitment and retention. Community engagement is a relatively underdeveloped area, but with respect to health equity, we've formed a health equity task force to look at how we operationalize the care that we deliver to our publicly versus privately insured patients.
Thank you. Let me now go back to Dr. Vanessa Rouzier. Dr. Rouzier, we lost you a little bit, but I actually wanted to ask you another question in follow-up to Dr. Safford's comment about the relationship between access and healthcare quality. What I wanted to ask is, what strategies have you used in Haiti to improve access to healthcare during the COVID outbreak?
Thank you for the question. And really building upon what Dr. Safford said, access and behaviors are really key, and also linking into what Joy mentioned about the need for education. So in terms of access, it was important for us to provide a safe place so where people could come in. Before we had our first confirmed cases, we started screening our own patients at the clinic and educating them about what COVID was. Anytime you have a new pandemic, you have a new disease that comes in, fear sets in. And it's funny how myths and misbelief, misinformation spreads faster than true information. So it was very important for us to provide education and a safe place for our patients, for our population to feel like they could come to and start to build that trust. Because the fear spread so quickly that people were disengaging in care. So even patients that had a long-term relationship with us, even our HIV patients, who we follow for a long time, would be afraid to come back to the center because of miscommunications and really poor information that was circulating about vaccine trials that were going to be used. The Haitian population was going to be used as guinea pigs for COVID vaccine trials, and that the testing kits were contaminated, that it was a foreign conspiracy to really kill people. So it was really important to engage initially with our own population, with our own patients, provide education, provide prevention barriers, educate about social distancing, which is really very difficult and really challenging when you have families that live 10 to 12 people in a little tiny room. And how do you adapt that messaging to a local community and make it feasible for them? We provided masks, obviously, distribution of water buckets, distribution of soap, and engaging them and encouraging people to come in for testing once testing became available. Because like Dr. Safford said, sometimes even when you have the best health centers, if the people don't come in, you can't save them, which became a very challenging part for us during the pandemic. We initiated measures very early on. The Haitian government really closed things down really early. But by the time, and it gave us time to prepare and set up COVID centers and educate our population. But then, despite all of that, we had a significant percentage of people who were afraid to come in or would come in very late. And behaviors we saw were very important and contributed to those poor outcomes because people would come in at the last minute and it was hard to save them. So I would say strategies that really were important, and I think those apply both to US and non-US based settings, is the community engagement. It's really key to reach out early on to local partners, to grassroots organizations, and spread that messaging in a manner through partners that are trusted by the local communities that have poor access to care. Because it's important for them to trust the message. When we use a top-down approach, the government started sending out messages. There was such a distrust in the government that people wouldn't believe what was being said. It was really important to reach out through community partners to get the messaging from people they trusted so that the access would be seen as something that was trustworthy, because we had beautiful COVID centers that were set up, but then people wouldn't come in. So access and behaviors and education are absolutely key and intertwined. And to tie on to what Dr. Safford says, social justice really is determinant for health equities. In Haiti, I think maybe people wouldn't necessarily understand what the role of racism would have to play, but we were the first Black independent country. We kicked out a colonial force, the Napoleon's army, in 1804, but then sadly, that very racist structure was perpetuated. The next person in line, the mulatto elite, took over, and we did not address access and equity in healthcare. So we have a very racist infrastructure, and systemic racism continues in Haiti, leading to really poor access to the most vulnerable people and lack of healthcare coverage and education as well.
Yeah. You know, what's interesting about what you just said, Dr. Rouzier, is the importance of trust in healthcare delivery and in care delivery. In fact, in one of the town halls that we had on diversity and COVID crisis about 2 months ago, we invited the CEO of NYP, Dr. Steve Corwin, and one of the questions he was asked was, what could we have done differently in order to sort of improve care for COVID? And he mentioned the issue of trust. He said that initially when we were sort of panicking about the PPE availability and rationing to some extent inpatient care, we sent many patients home with the understanding that they will call back and come back to us if they really didn't feel well. But a lot of them didn't come back. And part of it is because they were concerned about what happens to them. Would their families be able to come and visit them? So you're absolutely right that sometimes the trust level that patients put in us, those of us who are caring for them, really impacts how well we can care for them. Let me go back to Dr. Safford. I wanted to, Dr. Safford, many of us, you, myself, and others who do health disparities research, we always like our research to ultimately impact how we deliver care, how we provide care. I was just wondering, how can we change the ways in which we perform clinical practice? What sort of things could we do to effect change?
There's a lot that we can do. So I think one of the most important things that we can do is to try to engage and encourage more minority physicians, especially Black male physicians, to become doctors. There was a really elegant study that was reported a couple of years ago, a randomized trial of relatively indigent African-American men in Oakland, California, who were asked to see a doctor for preventive services counseling. And they then, after they saw the doctor, they were asked, so which of these services do you want to take? And unbeknownst to the doctor and to the men, the manipulation in the experiment was the race of the doctor. And the Black men who saw a Black doctor were much more likely to accept the preventive services. And what's really remarkable about this study is that they asked the men, the patients, how nice was the doctor? There was no difference in the ratings that the men themselves had for white doctors or Black doctors. They liked them the same. They said they trusted them the same. But it really, the underlying mistrust is not necessarily something that the person is going to tell you, or even that they themselves perceive. So I think we have a crisis in having too few physicians of color. That could be a very quick solution if we could figure out how to help them to get through medical school. I think the second big thing that we could make a very quick change on is something that is the focus of a lot of my studies, is peer support. So you take people from the communities where people live, you train them up, very minimal training, and they basically are the trusted source. They help people to understand the doctor's advice, which is a big problem. Make sure that they get to the pharmacy to get their medications, that they can afford their medications, help them to get childcare. If they have a doctor's appointment, they don't want to cart the kids along, figure out transportation. If they have cancer, this has been shown very, very elegantly. If you have peer navigators that help cancer patients make it through their entire cancer treatment, first of all, they finish the treatment, which is currently not happening unless they have navigation, and they do better. Expanding our conceptualization of healthcare teams, sorry, I'm going to just turn this right off, is to envision that we can really have a healthcare team that is composed of slightly different people than we currently have. There's already a similar model to this in many practices, and I think Dr. Howell's practice has this in pediatrics, community health workers. But peer supporters are slightly different in that they really have to come from the community, and they contact people frequently just to check in and see how they're doing. And in our hands, this has really been a remarkable, effective technique to help people from the community to engage. And that trust factor is really what that helps to engender. So I think there's a lot that we could do, but it would require different creative thinking about what healthcare should look like and the types of people who should be on healthcare team.
Thank you. Those are excellent points. I wanted to go back to one of the first words you said, increasing the diversity of the medical workforce. Yeah. I think that's actually one of the most effective ways that we could improve the trust between the communities we serve and the sort of the care we provide. And I have to note that one of our long-standing iconic programs called the Summer Travelers Program is intentionally designed to address that issue. I don't know how many of you know about this. This is a program that's endowed by the generosity of the Weill family, and it has been in existence since 1969. And it brings to our campus 25 college students every year from different socioeconomic and ethnic and racial backgrounds. And it exposes them to the healthcare environment, connects them with researchers and mentors and colleagues and medical students. And we track how many of them go on to go and attend medical school. 83% of them have been attending medical schools. 96% of them have graduated from medical schools and are now physicians. Some of them are actually directors of NIH institutes. It's programs like that that we need throughout the country so that we can increase the representation of minorities in medical schools and therefore diversify our medical workforce. So thank you, Dr. Safford, for pointing that important issue out to us. Let me, it's actually now 5:42. Why don't I sort of stop asking our experts questions and now turn to the audience to ask questions. And I'm happy to read the questions as you post them on the chat room and post it to the experts. But while I'm waiting for you to ask questions, let me start with one general question for all of our panelists. What are some of the largest challenges to addressing health disparities? And any one of you can go ahead and answer that question.
I think one of the most urgent things that we need to do harkens back to some comments that Dr. Safford mentioned earlier, which is address America's, what I like to refer to as our congenital disease of racism. In drawing from a quality improvement analogy, we often look at adverse events that drive us back to the root cause. And sometimes we perform what is referred to as a root cause analysis. We need to understand America's history with racism. We need to understand the vestiges of that and the structural racism that still exists to this day, how it impacts the social determinants of health and feeds into healthcare disparities.
Yeah, I could not agree more. I think that the big issue that we need to face and confront is we need to embrace our past. We need to embrace the fact that our founding fathers were white supremacists. It's not a pretty picture, but that's what they were. And we shouldn't. In South Africa, children learn about apartheid. In Germany, children learn about Nazi Germany. In the United States, we don't learn about Jim Crow in school. We should. We should learn the unvarnished truth. And only by going back and embracing what our roots are can we decide that we want to head in a different direction moving forward. If we don't, it just keeps popping up in various forms. We had slavery. I mean, it's a small miracle to me that there's a group of people in our country who were slaves for the majority of 500 years, that they haven't risen up in violent protests more frequently than they have. Wouldn't you? It's this systematic and continued oppression is something that we simply have to acknowledge and decide as a country that that's not who we want to be, and we want to move forward in a different direction. That is the single biggest challenge that we face, is making that happen.
We have a question from the audience. We have a question from David Jacobs. So given what was just said about the concordance between physician and patient for Black patients, should hospitals and clinics attempt to do that on a routine basis? I'll pose the question first to Dr. Safford. You're the one who talked about concordance.
Yeah, it would be wonderful if we could do that. Before we can do that, we need a whole lot more physicians of color than we currently have. That's the big crisis that we have in medical education in terms of trying to diversify the physician workforce. There are fewer African American males coming out of medical schools now than there were 20 years ago. So we have actually moved in the wrong direction. So it would be great if we had a huge cadre of physicians and we had that choice. We don't. So we have a diversity center of excellence here. Susana Morales heads that. Dr. Howell is very much involved in that. I'm the co-principal investigator of that effort. It's entirely focused on trying to increase the diversification of the workforce. I also have to call out Augustine Choi. His vision about how important diversity is just absolutely remarkable. And the extraordinary generosity of our donors that has allowed tuition to be reduced for people or eliminated for people who need it has opened the door to really allowing people from disadvantaged backgrounds to be educated here at one of the best medical schools in the entire world. Those kinds of initiatives is what we need more of.
So before I go to the other panelists, let me add a little bit more from my perspective. I actually do not believe that we need a segregated care. That's not really sort of what we are proposing or what we think the research actually indicates. What we need is a healthcare system that's reflective in terms of workforce of the communities that it serves. But patients are really sort of just need a good care. And they are happy to get it no matter what the race or the ethnicity or the gender of the patient is. So I think the idea is to diversify the workforce enough for patients to feel comfortable that they are getting care at a place that they can trust, rather than whether they have to be matched, one-to-one with somebody of their race. Patients have the right to do that. In fact, when I was practicing primary care at many VA hospitals between Philadelphia and Cleveland and Pittsburgh, I often had patients who came to me because they thought I was the only African-American primary care doctor. But 80% of my patients were not African-American. So it's okay for patients to sort of, if they want to seek that kind of specialized care or sort of concordance. But the fact is that what we are advocating is a diversity of the workforce, not a one-to-one race matching. Let me, anyone else want to add to that? Dr. Joy Howell or Dr. Rouzier?
If I can jump on the comment about acknowledging American history and really the fact that racism was part of this history, I think when we say that, it scares many people. And I think it's important that we also acknowledge that this needs to be done in a safe way and in a brave way. I don't remember if it was Dr. Howell or Dr. Safford who said that, brave conversations, because the impact of racism, the legacy of racism has been on both camps, if I may say. A lot of white people feel like they have a guilt, the historical guilt that they're carrying, that they're not responsible for. And I think it's important that we embrace that conversation in a very comfortable and comforting way. But I think it's absolutely key that we come to terms and we say it, we embrace it, we celebrate it, and we heal from it. And I say this living in Haiti, where we've not done that. We have not healed from our past. And there's a lot of wounds that we still carry as a society, as a nation, internationally as well. Unfortunately, French books don't talk about the slave revolution that led to the first Black republic in the world. It's unremarkable. It's really remarkable that we can suppress our history because we're uncomfortable. We're uncomfortable to talk about it. And it's important, the research that we do, it's important to highlight that we need to do this healing because it hurts us. It hurts the healthcare that we provide. And it's not only the healthcare, obviously, but the whole society suffers for it. And I really want to highlight back to this topic because I think it's very important.
Thank you, Dr. Rouzier. We have another question from the audience. This one comes from Dr. Kenneth Jones. Dr. Jones says, as a graduate of the Summer Research Program, which is the program I just referenced, in 1974 is when he graduated. He graduated in 1978, I should say. He practices now medically underserved medicine in medically underserved area in Jacksonville, Florida, and he's been doing that since 1983. His question is, how do we encourage young African-American men particularly to pursue careers in medicine? So anyone from our expert panel who wants to respond to that question? How do we encourage African-American men to go into medicine?
Saeed, if I may.
Yes, please, go ahead, Dr. Howell.
So addressing the social determinants of health, one being education, addressing entrance into medical school doesn't start to feed the pipeline early enough. We've got to go back to high schools. We've got to go back to junior high schools. And to Dr. Rouzier's point, we've got to address our
We lost you again, Joy.
history studies that demonstrate that if a young child is exposed to an African-American teacher, they have a greater likelihood of completing their high school education. And so I think that one important way is looking for every opportunity to address the pipeline as early as possible, as early as elementary school.
Thank you. Any other thoughts from our other experts?
Yeah, I mean, I can tell you that, we have a big education mission, as I said, led by Susanna, and Joy is very prominent in that Diversity Center of Excellence. And there are a lot of programs that we put on in middle schools and high schools. And it's amazing how many stories we hear where a kid decides in middle school that they want to become a physician, and then they get to high school counseling and career counseling. And part of the problem is the counseling. Because they're told that it's not for them. I mean, I'm sure many of you have read Michelle Obama's memoir, and she was told she wasn't Princeton material. So the counseling is part of the problem. And then when you get to colleges, if you manage to get in, there needs to be much closer hovering and help, and acknowledging that it's hard and you failed this test, but you're not going to fail the next one. And more hand-holding. We need more services that are dedicated to making sure that these young people succeed, and that they get the right advice, and that they're encouraged to pursue their dreams, not told that they shouldn't or that it's not for them. So I think there are multiple strategies that we need to take, and I completely agree with Dr. Howell. It has to start in middle school before people get turned away.
Let me add to that. I think that, as everybody said, there are multiple ways that one could encourage young African-American men and to pursue medicine. Of course, one of them is exactly what the Summer Travelers Program is doing. And a success story is Dr. Kenneth Jones himself. So it's important to expose young people to successful role models in medicine. To make them comfortable with the academic environment. That's what the summer program does. But does it have to be only for college students? Could we go even earlier in high school and in elementary school? Of course, we could do it. But there's also another way that we could increase the number of minority students who go to medical school, and that is to make the cost of medical education affordable. Fortunately, Weill Cornell Medicine has taken a really important step in that direction when they adopted the debt-free sort of a strategy. That's really the beginning. So if we have highly qualified young people who are coming from disadvantaged communities and they want to pursue medicine, we have to make sure that they can financially do so. And I think that's also another way to do it. And not only one or two schools should be doing this. All medical schools should find a way to make the cost of medical school cheaper, or if not free.
Saeed, let me just also add on to that. You're absolutely right. The cost is a very big huge issue. But the other thing is the admissions criteria. So one of the things that we're really trying to push here is holistic review. So if you come from a not so good high school, you're not going to do so well on your SATs. You're not going to get into the best college. You're not going to do that well on your MCATs, but you could be a whippersnapper smart person who would be a fantastic doctor. So recognizing that people from disadvantaged backgrounds are unlikely to do as well on standardized tests is another very important step to de-emphasize the test scores and to emphasize the whole person and their potential. And holistic review is not new. It is something that's been talked about for a very long time. It's time that we implement it if we're really serious about this.
Yeah.
If I can add in really quickly.
Please. Go ahead, Dr. Rouzier.
Debt forgiveness, loan repayment support strategies also are very successful ways that we can support minorities. And then the other comment really quickly is to have mentorship of people from underrepresented minorities. It's staggering the numbers of underrepresented minorities that are in basic science, that are in leadership positions, that are heads of departments, chairs, deans of medical school. Really, visibility counts, and promoting that and promoting our peers I think makes a really difference in bringing in people and making them feel comfortable that they too have a role and a place to be.
I just wanted to also note a comment from one of our audience members, Dr. Leslie Hayes, who graduated from the Summer Travelers Program, class of 1981, said that she's currently the chief of adolescent medicine at NYP in Brooklyn. And she's concurring with all of you that pipeline programs that reach into college students, into high schools, to entice young students from socioeconomically disadvantaged backgrounds to pursue careers like medicine are really important. And it's fortunate that we actually have numerous of them. I mean, Weill Cornell Medicine has more pipeline programs than probably any other medical school in the United States. And I think we're very proud of them. Let me see if there is another. It's actually now 5:58. I was going to say, are there any other questions or comments from the audience? But at this point, what I would like to do is probably get close to ending it. I wanted to thank all of our panelists for today's important and thought-provoking discussion. And I also want to thank all of you, the attendees, for your insightful questions and for joining us for this first webinar series, Weill Cornell Medicine Insights. Now I would like to turn things back over to Dr. Dean Joy, I should say, for a closing message.
Thank you, Dr. Ibrahim, and a big thanks to each of our three panelists. I'm very grateful for all your work and leadership around these challenging and complex issues. To all of you tuning in today, thank you. We know your time is valuable, and we are deeply grateful for all you do for Weill Cornell Medicine. If you're interested in supporting the work of Weill Cornell or learning more about any of the faculty participating on today's panel, we'll be following up with more information over email later today. We hope you'll consider getting more involved and are grateful for your interest in Weill Cornell. Please join us for our next webinar on Thursday, August 6th, Peas in a Pod, Mental Wellness for the Entire Family. We hope to see you then. And in the meantime, please stay safe and well.